Hello, and welcome to another episode of Navigating Cancer. I'm Dr. Joey Bennett, joined by Wendy Hall, our clinical social worker at the Robert Boisonneau Oncology Institute. How are you?
I'm very good. Nice to be here.
It's great to be here, and we've got a very special guest with us tonight. We're always excited when we can offer something in this community that we haven't had before, and Dr. Farhad Golkar is a surgeon new to the area. He is part of Emeritus Surgical Associates. His undergrad work was at Emory, and then his residency and his medical school were at the University of South Florida, and then he did a fellowship in hepatic and pancreatic biliary surgery, which basically means stomach, esophagus, liver, pancreas. So welcome to the show. We're glad to have you on the show, and we're very happy to have you in the community. Dr. Golkar brings something to the community that we haven't had, and that's really the surgical ability to handle a lot of the cancers in this area. And that's why we wanted him to talk about this tonight. When you have a surgery for a cancer, it's awfully nice to have it close to home so that your family practitioner can be there to help. And if you have an emergency, you're right there with your surgeon instead of having to drive to Tampa, Orlando, or Gainesville. So we're going to cover a couple of topics tonight. First one we wanted to talk about was pancreatic cancer.
Yes, well, thank you very much for having me. So pancreatic cancer is not that common of a cancer, but it is a rather lethal cancer, and it is the fourth most common cause of cancer deaths in the United States and in the world. There's 35,000 new diagnoses per year, and unfortunately, similar number of deaths per year, and resection or surgery is the only hope of cure, along with other types of therapy such as chemotherapy and radiation therapy. You can get an idea of what 35,000 is with this slide here. This would be the incidence or the number of new diagnoses per year. And the next slide will show you, unfortunately, the number of people that would be alive after 5 years. And of course, there's too few to even be able to see from this aerial photograph.
I think that's an amazing slide to sit there and realize this is the University of Michigan football stadium, which holds 110,000 people, I think. And to realize that small section, Bill, if you can go back a slide, that small section in this corner was the 35,000 people. And when you roll back to that next slide again, you come into where the survivors are, and you just realize that it's a tough cancer to cure. Let's talk a little bit more about it, Bill. Go ahead and go to the next slide.
So what symptoms can you get with pancreatic cancer? You can get pain in the upper abdomen, just generic symptoms such as fatigue, weight loss, and most commonly jaundice. And actually, turning yellow is a good thing, as you see there, and we can talk about this in a little bit as to why that is. Many patients who are diagnosed with pancreatic cancer are also recently diagnosed or within 18 months of having type 2 diabetes.
I mean, one of the things I think that you've said before, too, is that sometimes being diagnosed with minimal symptoms may give you the best chance or none because it might be an accidental finding.
That's exactly right.
You've seen people in car wrecks who get scans.
Right.
And you find these things incidentally, and sometimes these can grow for a long time without symptoms.
Without symptoms, right.
But when we have someone that we are suspicious about, tell us about how we go about diagnosing this disease.
So to diagnose the disease, the mainstay here, you see many modalities listed on this slide, but the mainstay is a good quality CT scan, and that's what I use as a surgeon to determine if I can offer operative intervention on these patients. And we can look at some CT scans now. This CT scan here is a perfect example of a CT scan of a pancreatic cancer that can be removed from a surgical standpoint. And I'd like you to focus on two things here. The red arrow points to a very important vein that I need to make sure that the cancer has not invaded or involved, called the superior mesenteric vein. And in this slide here, you can see the cancer is marked or delineated by a yellow circle. And so there's a nice plane or a separation between that big blood vessel and the cancer. And so that CT scan there is a good CT scan and means that I can offer surgery for the patients.
And I think if you look at the scan just from here, the yellow, I'm not sure how easy that's showing up, but that's the pancreas and the vessel that is there. So go to the next slide and you'll show us.
Right, so on this slide, you can see that the pancreas and the cancers are really close to the vessel. And in this situation, that vessel that, again, the red arrow is pointing to is not robust and round like in the other one, and it's kind of flattened. And in this situation, the cancer has grown into the vessel, and this patient is not a candidate for surgery.
And so you're capable of getting a lot of information about whether they can or cannot have surgery. And that's one of the things that we we know is critical when we're looking at patients who've been diagnosed with cancers. We're trying to sit down as a team, talking about the best way to go about managing those patients. And it's good that CT scans can give us some information that we used to not have.
That's right. Okay, next slide. This is an anatomy slide to give you an idea of where the pancreas is in relation to other organs. You can see the duodenum, which is the first part of the small intestine, wraps around the pancreas. And as you can see by the blue and red structures there are a lot of blood vessels around the area. I've drawn two circles on the screen, or ovals. One of them is purple and one of them is red. And those are the two most common places that pancreatic cancer occurs. The purple one is in the head of the pancreas, and that's where a tumor can happen and you would turn yellow. And so even when the tumor would grow a little bit, you would turn yellow, and that's why it's good. Whereas if a cancer grows where the red circle is, then it could grow and grow and grow, like Dr. Bennett was saying, and not cause many symptoms until it's become rather large.
And I think you can see that from the slide that you're seeing here and just looking at it as I'm pointing to it, there are a lot of critical structures in this area, and this is a very complicated surgery. And so now we can kind of go into the next slide and talk about how you go about treating this, because this is one of the toughest surgeries I can think of for any surgeon to do.
Right. So this diagram here depicts the original operation, which is called the Whipple operation. We've modified the operation somewhat, and the area that's in the blue circle is an area that we don't remove anymore, which I will depict in the next slide. This is the slide of the operation we do now. It's got quite a long name, as you see at the top, pylorus preserving pancreaticoduodenectomy, and essentially everything in orange on the top picture is removed and then reconstructed like you see in the bottom picture, with half the pancreas and the tumor removed as well.
And so you're removing some of the intestine as well with this procedure?
So we don't remove any of the stomach, but we do remove the gallbladder, the bile, the end of the bile duct, the head of the pancreas, and the first part of the small intestine called the duodenum. And then we connect everything back together.
Bill, go to the next slide real quick for us.
This is a picture of a tumor that occurs not in the head. Remember, this is a patient that won't turn yellow, and this is a patient who would get a different operation called a distal pancreatectomy and splenectomy, where we remove the other half of the pancreas and the spleen.
So a simpler procedure, but a lot of times, again, as you said earlier, that is not the location that you really want to have.
Right, that would not be the preferred location if you had to have one.
This is the first time with Dr. Golkar being in the community that we've had surgeons that really have subspecialized and done fellowship training in this type of surgery, so it has brought a whole new added benefit to the community. We're very pleased to have him, not just for pancreatic cancer. We're going to talk about esophageal cancer as well in the next segment. Stay with us.
Thank you.